Hi, my name is Farawi. What can I say? Today I'm gonna present my case study, biopsychosocial model of care. Now I'm gonna introduce my patients. Her name is Victoria. She's a 50 years old, single, female, Greek background. She's a mother of two daughters, successful businesswoman, bubbly personality. She's always laughing, and she's the owner of Cosmetic Injections Institute for Cosmetic Injections Clinic. She has a nurse background. She enjoyed traveling and eating out, drinking, smoking sometime, been living with her busy life for longer than 25 years. From 1990, she started to experience chronic left shoulder pain. 1995, severe migraine. 2000, lower back pain started. 2019, menopause and plus plantar fasciitis. 2020, rapid weight gain during lockdown. She told me she gained 10 kilos. 2021, diagnosed as early phase arthropathy. L4, L5, and S1, which is I convinced her for almost 4 months to get MRI done, and she's tried to avoid because she said she hated the result. For Victoria, impact on daily life, functional capacity, constant pain, poor sleeping, stress, mood swing, smoking and drinking, poor diet, lack of exercise motivations, mild social phobia, diagnosis, disease, chronic left shoulder pain, lower back pain, both feet pain from plantar fasciitis, migraine, menopause, fluid retentions, both legs, facet arthropathy, L4, L5, and S1. This is the model of biopsychosocial media. For bio is biological, is gender, disability, physical health, neurochemistry, stress reactivity, genetic vulnerability. Psychological is behavior, personality, attitudes, belief, learning and memory, coping and social skill, self-esteem and emotions. For social cultural, it can be education, social support, peer relationship, family background, socioeconomic status. And the next one is pain, the brief pain inventory, with BPI. BPI is self-administered, like questionnaire that was original designed for excess cancer pain. It is now used for generic pain questionnaire. For other chronic pain conditions, it is available in short 9 items. For long is 19 item form. The BPI gives 2 main score. For the first one, the pain severity score, how much is your pain. The second one is pain interference score. This is for Victoria for her pain presentations. She marked at her left shoulder blade, left lower back, and also both feet. She gave them pain severity at 8. For pain interference is 5. For Victoria, she gave depressions at 8 score. Anxiety for 10. Severe stress 18, which is quite high. For general psychological, stress is total is 36. How is effect for psychological factors or depressions affect its impact, possible associations, pain severity, pain behavior level, disability, clinical considerations, eating disorder that to compensate her depressions, referrals, psychologists for anxiety, unpleasant affect state, anxiety, fear, anxious patient's pain experience. For she said she mentions mood swing, so I would recommend or referral psychologist. For stress, stress significantly amplify negative mood, post pain experience. For Victoria, she got my headache, digestive issues, sleep disturbance. Referral also psychologist. Anger, feel uncomfortable with herself, avoiding socializing, mild social phobia. Pain can cause anger, and also pain can affect to the patient's behavior. Referrals can be anger management and psychologist. For pain catastrophizing score, PCS, pain catastrophizing affect how individual experience pain. Like measured by the questionnaire. Ruminate is means I can't stop thinking about how much it hurt. Magnify, I'm afraid that something serious might happen. Helpless, there is nothing I can do to reduce the my intensity of my pain. For Victoria, she pretty good. Illumination is 3. She just avoid and then coping with that pretty good. Magnifications 4. Helplessness is just 1, which is good. Diagnosis for Victoria is left shoulder chronic pain. Disability, how is affect is disability positive characterizations between back pain and refer pain. For her plantar fasciitis, walking difficulties, severe heel pain. For migraine, lack of concentrations, severe troubling pain, and pulsing sensations, facet arthropathy, associated with increased perceptions of disability. Cognitive factors, self-efficacy. Self-efficacy belief and pain behavior is prospective study examine like the relationship between pain, self-efficacy, belief, and the range of pain behavior as measured by the pain behavior questionnaire (BPQ), cognitions and core schema. This Victoria, she has a positive personality and resilience, was sufficient to endure like 12-month goal at the beginning. But since she failed that, she struggled to find the energy and motivation to reset her goal. She recently scored 8 from PCS, validative schemas, more prominence at last 6 months. For Victoria core schema, clear thinking, positive persons. She still believes like the treatment will help her, will cure her. Exposed to pain education through treatment of conditions. She has a good understanding about her pain. Dispositions to be anxious about specific thing. No clinical history about depression or anxiety, and no medication history. Maladaptive scheme, more prominence in the last 6 months. Cognitive factors, belief, fear, avoidance. Impact, more how is pain and fear, belief affect that person's. More emotive thinking or exaggerates pain perceptions. Validative pain behavior, lower back for Victoria's, lower back pain and plantar fasciitis, left shoulder chronic pain. As theory, we believe fear is avoidant behavior and opens cognition. Pain and fear, the scare for and fear for the further injuries. So instead of to protect that, we have like protective behavior. Low back pain for Victoria is for many years, and she tried to avoid sitting, reduce activity level, pain decrease. Yeah, but once I told her to get MRI done about her lower back, she tried to avoid to get MRI done I tried to convince her for 4 months. Assessment for Victoria, like the understanding about her condition is pretty good. She understands now like what's going on, what's wrong with her. Is her lower back pain stop her from doing things? Yes, so something. For Victoria, so see a cultural factor. Social and family adequate and strong because she got Greek family background and good relationship with her parents. She tried to walk regularly with her dogs, but she feel guilt of how she had to stop during her walk to alleviate the pain. As she been living with two adult daughters at the same house, and everyone have have busy lifestyle. So at some point, at some degree, she feel isolated. And regarding to her mood swing from menopause, Victoria enjoy eating out and feeling guilt at the same time for her overeating. For her workplace and peer relationship, responsibility for the company. Yes, of course, and work with many staff, and but good thing is her financial is stable. Victoria coping style, adaptive, exercise compliance. She commit to do exercise and then move her body. Understanding and apply great exposures, very good. Passive treatment, I did soft tissue massage and also some mobilizations for her bones and also lymphatic drainage. It's temporary relief. Maladaptive, fear avoidant and productive sometime or at some point some month she can overuse for treatment. Like she's seeing me as a myotherapist, and she's also seeing osteo, and then she also seeing chiropractor. And sometimes she said she increased her alcohol consumptions. She said she cannot go to bed, so she said maybe alcohol. She believes alcohol can help her. For her socio-cultural factors, what impact the state of habit, role, and quality of life for Victoria? She's a successful businesswoman. She running her own company, so she has confidence and social friends and employees and pretty good quality of life. She loved exploring new restaurants with her friends, walking with her dog in the garden to keep herself active. And this is the model for Victoria, biopsychosocial model. For biological, as you see, will be pain intensity, pain interference, and all those conditions for Victoria. And psychological, and adequate and strong, menopause, traditional Greek family, financial stable. At some point can overuse all the treatment. Social cultural, affective state, depression 8, anxiety 10, social stress 18, self-efficacy and fear avoidance for social cultural. The last one will be boundary within clinical myotherapy practice. Myself, I try to give her all the education to her, like for her conditions and her pain, how to avoid, how to manage, and then the movement educations, constructive dialogue, relationship between coping mechanism and pain in the defender, not the offender. FABs and DAS such as PTSD and referral to psychologists. If 12 months is contraceptive treatment without consumption improvement, I would suggest to see pain specialists. Okay, that's all for today. The last two will be reference. Thank you.